Yeah, so this title is Thinking on Your Feet. So the first question to our panelists. Here is a patient where you have operated. It's an uneventful surgery, intra-op. It's a trifocal patient and you have a post-operative refractive surprise of minus 3.5 diopters. The patient has come to you second day post-op. What will you do? How will you face this situation? What all will you look for? Aldipurkar sir, Nagvekar sir.
Well, if the post-op refractive surprise is 3.5 and if the surgery on the slit lamp looks uneventful, then it's really a surprise. So, I cannot...
What all will you look for on slit lamp, sir?
Now, obviously with 3.5 spear, well, I mean, in the post-op on a slit lamp, you see the position of the lens, whether the AC is shallow,
Right.
whether the lens is pushed forward, and or I would also look at the fundus to see if there's some edema posteriorly, where somehow the thing has been. But then, if things look good, so we obviously know that it's a case of missed target, and in that case, counseling-wise, obviously on the first post-op day he won't come to me unless I have operated. If I operated this patient and comes to me on the first post-op day, well, I kind of tell him that, look, I mean, I can't tell him 2 weeks later, let's see, things will improve. It's probably not going to improve because it's too much. So I would say there seems to be some amiss here. And if your, your refractive error doesn't really come down, we may have to go in for another procedure. That's what I would say.
Yes, but before we even go on to the counseling, now, like you very rightly said, if there is a, yeah, Dr. Nagvekar sir, yeah.
Hello. So, I think I would...
How would you approach this case?
Yes, I would probably, but be a little more aggressive than Dr. Suhas. In the sense that what I do is the same thing that I told you all in mistakes in toric IOL surgery. You go back and do the biometry again. Of course, after finding out on the slit lamp that the anterior chamber depth is as expected, then the only other possibility that I can think of is either a mislabeled IOL, okay, or there was a wrong biometry. So in which case, I am going to do the biometry again.
So the first step is on slit lamp, you look for a wound leak. You see if the anterior chamber is shallow, which means that the lens has moved ahead.
Yes.
So the anterior chamber is shallow, IOP would be low. Probably there would be a few fine corneal folds which say that the IOL power is right, but it is the anterior chamber depth which is reduced, which has induced the myopia. Correct? So that would be the first differential diagnosis. Now suppose the anterior chamber is mildly shallow, and would you think of a capsular distension syndrome in this case?
Not so early.
Why not?
Capsular distension syndrome, at least as what I understand, is something as a complication of a posterior capsular opacification.
No, sir. No. What I'm saying is, you have done an excellent rhexis, but there is a 360-degree overlap. And the capsular distension syndrome is where you will have fluid accumulated behind the IOL and between the posterior capsule.
But you're talking of an...
That will, yes, but it's not a wound leak.
You're talking of an aqueous block on the CCC, correct?
I'm talking of a capsular distension syndrome, not even a misdirected. So basically, it's not a wound leak. It's a capsular distension syndrome because the CCC has completely covered the IOL, and now there is fluid that has... See, many times when you're doing the last IA, there could be a little fluid behind the lens. We have had such situations in the past.
Fluid behind the lens would always be there if you're seeing a shallow AC and the wound is good. So that means what you want to say is there's a lot of fluid behind.
Yeah, so if you do an OCT, AS OCT for these patients, you can see a difference in the space between the posterior capsule and the IOL. So you know that it's not a wound leak, but it's a fluid that is accumulated. So the entire thinking process and the treatment line would differ. Then you would not want to do an IOL exchange, but you would want to remove that fluid.
You would anyway wait.
Yes, so now you would wait for that fluid to get absorbed. Maybe you would start the patient on, you would probably step up the steroids. see for a few days, and if it doesn't, then you would go back and tap the lens to get the fluid back anteriorly, so that, or and remove that fluid. So we have had a patient like this where there was no wound leak, but there was fluid accumulated behind, causing anterior shallowing and the IOL coming forward, diagnosed on ASOCT. So we waited for 2 days. It didn't stabilize at all. It didn't reduce because there's no place for that fluid to go. So we went ahead and just tapped the IOL. That fluid came out, gave it a wash, and then the patient was fine. So this is something that you just need to remember, that it may not always be a wrong biometry. It may not always be the wrong lens, which also you should remember, but it's just how to go on with once you see a patient like this. So suppose everything else was normal, then probably you would go ahead and do a pseudophakic biometry and then check whether the IOL power was right. Am I right, sir?
Yeah, that's what I was thinking.
Yeah. So
I would
if
do a
this was not the
pseudophakic
case,
biometry anyway,
if the
because it's
anterior
this-
chamber depth was normal,
yeah,
then you would do a pseudophakic biometry and check whether a wrong IOL has been put
or a mislabeled IOL.
or a mislabeled. And then there is probably no other option with a 3.5 diopter. There's no other. So now if it's a wrong IOL, at what point of time would you an IOL exchange? Immediately?
Yes.
Because you have no option.
Yeah.
3.5 diopters is not something which you would keep.
No.
At what point of time? Suppose instead of 3.5, it was a 1 diopter minus 1, say for example. Would you wait till a month for it to stabilize and probably do a touch up, or would you do an IOL exchange? Because this is a trifocal.
For a -1, obviously there's no interaction, intervention done immediately. And your post-op biometry has shown that things are okay, then you definitely wait. Even if the post-op things say that, well, you have missed it. Even then, whether for -1, would IOL exchange be your treatment of choice, or you would go for less invasive ones?
What is your
Like if it's
take?
3.5, 4 and all, then obviously the patient needs IOL exchange, and then there's no point in delaying it any further.
Yes.
But if it's -1, maybe for 1 month, I wouldn't do anything.
So because the more you wait, the more the fibrosis would occur along the capsular excess margins, and the more difficult it would be for an IOL exchange. See, when you're doing a trifocal, the patient has been, his expectations are sky high, and he is saying that he's not able to see. So his vision, uncorrected, would drop to 612, 6.9, and he is not happy. So for the next 3-4 weeks, till the decision of IOL exchange or a laser touch-up, he's going to come and eat your head at every visit. And you know that you have missed target by 1 diopter. You know that it's probably a wrong biometry. So at what point of time would you take that decision? Because if you wait for a month, then at that point of time to do an IOL exchange would be more difficult than by doing it in the next week.
So I think I would start talking to the patient immediately. See, there's no point in keeping the patient in the dark or saying that, this will improve, when we ourselves are not sure whether this will improve or not. So probably I would talk to the patient and open up 2 possibilities here. One could be an IOL exchange at the end of it all, whatever the time period may be, or maybe even, introduce the concept of bioptics. A 1 diopter, if it is bothersome, I would not hesitate to do a surface treatment for such patients.
So one more question, if you're talking of LASIK or ASA,
Yeah.
in this patient post-op, it's already a multifocal diffractive technology trifocal, where the contrast sensitivity has already reduced. Now we are going to introduce a multifocal, on the corner. So
Just
how are
one
you?
diopter. One diopter will not make. I've done. That's why I'm telling you. One diopter. The problem with that particular patient, I remember, was that his halos were terrible. Once you land up with a diffractive multifocal and you make the patient post-op myopic, those halos increase tremendously. So in this patient who was more than 6 months post-op, okay, we discussed this possibility. It was not operated by me, mind you, but it was a very, very good, well-done surgery. So we did not hesitate to offer him a surface treatment. We did a surface treatment, and I think the patient was overjoyed, because with 1 diopter, I don't think, how much
But
tissue
after
are you going to
LASIK,
remove?
if the glare and halos would have increased, then how would you have?
No, with one diopter, hardly any tissue being removed.
Okay.
Yeah.
So
And
we'll
with
move on to the
due
next
respect
talk.
to surgical skills of anyone, IOL exchange is not a cakewalk. And to do an IOL exchange, if your original incision has been 2.4, you can't get the lens out to 2.4. You have to make it either 2.8
Yeah,
or
yeah.
2.9. And in doing that, and in the process of getting that lens cut and taken out, some amount of corneal aberrations do happen. And then you're going to put another lens. And this time, you have caused little more surgical induced astigmatism. So it is extremely difficult to titrate it. So unless it's a big refractive surprise where the exchange is better than a surface or LASIK treatment, I would opt for this.
Okay. We move on to the next case. A 54-year-old female, one eye operated elsewhere with edophavity, unhappy with the near vision, maybe because she was not counseled that she would need a reader. Wants better near vision, has come to you for the other eye. Now there's already an EDOF in the first eye. What would you do for the second eye?
What is the unaided distance vision in this first eye?
Distance vision is 6/6.
And what is the near vision?
Near vision is in
24
24.
and 18.
I mean, definitely not happy reading at all, and all she wanted was good reading. So this is very, very important. This stresses on the importance of counseling when we are using EDOFs, because most of them are not aware. They just feel that they will get more multifocality, but they are not aware that they will need a reader. And now you have to operate. And in fact, she's also saying, what can you do for the first eye? And she is almost 3 weeks operated in the first eye. How would you, and now there's cataract in the other eye. What would you do for the other eye? What would you use?
Yeah, first of all, this patient should not have been probably counseled for the EDOF.
So,
If
but
she was
elsewhere, done
on,
elsewhere. We don't have
but I'm just
control
saying,
on
I'm
that.
just saying.
Yeah.
If suppose a patient comes to you primarily and tells you that I want to read without glasses, okay, then I don't think you should promise an EDOF unless you're doing some kind of monovision with these patients. That is one. So I asked you what is the first refractive error. So if she's emmetropic in the first eye and I have to put in the other eye, counseling her completely about everything that can happen, I'd probably put in a trifocal in the other eye, because that's my best bet of giving her visual goal, which is to read without
Which
glasses.
trifocal?
I think
And we have no financial interest here,
Yeah,
so
yeah,
we can.
please, yeah.
This is
So-
for the benefit of the audience. Which trifocal?
So now if the patient's eye is absolutely healthy in all respects, doesn't
Yes,
have
it
high
is.
order aberrations, doesn't have dry, has a pristine macula,
Yes.
I think I would probably put in a panoptics as my first choice.
Haldipurkar sir?
Well, I would, after having used all the lenses, if you want to be absolutely sure. But then in this case, whether I would put a trifocal is a matter of discussion, because in the first place, probably I put EDOF because EDOF is a better quality. Now, after he has experienced a clear quality
Wants,
for
sir,
distance,
patient wants good near vision. She's not happy. She doesn't want to use glasses
when
for
she
reading.
says she wants good near vision, which doesn't mean she is okay with distant vision.
No, she's okay with distance vision, but she doesn't want to use
No,
glasses for reading.
The human tendency is whatever is good is not mentioned. Whatever is subnormal is mentioned. So in this case, if the patient says my near vision is not good, at that time, before if I put trifocal, if I do not tell her that with trifocal, you'll always have the difference between trifocal and VBT distant vision. I think
So, but with a trifocal, you will get good distance vision.
not when you compare it with a
Yes.
non-diffractive lens.
Agreed. So, what we had this patient, and we explained to the patient that only with a trifocal she will get good near vision without glass. But obviously, the principle of the IOLs in both the eyes will be different. So, she should not compare each eye, both eyes, all the time. We went ahead and put in a synergy. She got very good near vision. But then she kept saying that, can you do something about the first eye? Which we said, no, we cannot do anything. Your vision is good for distance. We just forget about it. So now, without glass, she's reading 6/6. Without glass, she's reading N6 with the second eye. She's happy as of now. We had explained to her that there could be glare and halos which would be different because we had put in a trifocal. The contrast sensitivity would be different. But that she will have to accept. Otherwise, if she was not ready to accept that, we would have put in an ADOF with micromonovision, but she was not ready for that. She wanted good distance vision also. That is why we did not go in for a micromonovision. She was very clear that she wanted to read without glasses.
At the end of it all, she's happy.
She is very happy.
Then fine,
So,
forget it.
In this, Dr. Anagha, I would want some discussion, if it's relevant, on the dominance. Now, presuming that patient was right eye dominant, then she had better chances of being happy because the left eye is used for near. A dominant eye has having a good quality. So, having said that, do you believe in your practice in the dominance of a particular eye?
not really so much.
Not really. What about you?
So, yes, even I don't pay too much attention, but once in a way you need to. It is very difficult, actually, as I'm going to say in the next course, to find out what is the dominance in a geriatric age group with cataract in both
With
eyes.
cataract.
How are you going to check for dominance? It's very
It
difficult.
may not be reliable.
Yeah. You just ask some certain things like which eye do you close when you have to shoot, or which eye do you put to your hand when you're seeing through a pinhole. So those are very gross methods, and it's very difficult to do that. And
No, but that will not matter as much
yeah,
as when you are going to put different quality lenses in two eyes.
that is true.
Presuming
Yeah.
this patient was left eye dominant, all right? No, right eye dominant, and the EDOF was put in the left eye because left eye was operated earlier. Okay, and now for the right eye, you're going to put trifocal lens.
Yeah, but then I think I would still put, because she said unaided EDOF vision was 6.6.
Was 6.6 for distance, yes.
Unaided EDOF vision, the eye with the EDOF had 6.6 unaided vision for distance.
Yes.
So I think you can probably, I mean, there has been a compromise all along. So a small compromise may not matter too much.
But
Would
what
you
will
be
happen if you
concerned,
put EDOF with monovision?
She wanted good distance vision also. Her only work was watching television and mobile.
And eating the doctor's head.
Very good near vision. Why synergy?
Yes, sir. But then
Even a minimal
synergy,
proxy would have done the
we
job
had.
for
See,
near.
I actually measured. I asked her to hold the mobile at 30, and she held it, and we measured it. It was perfectly 33 centimeters. So I thought at that point of time, synergy would give the best results.
Another option can be minimal proxy.
Minimal
also.
proxa,
Yeah,
yes,
that's
but
a good suggestion.
that's a good suggestion.
Monofocal lens, the distance is good with one eye, the other eye we can manage with this.
Lucidis
So
also
coming to
has
the
a
next-
+3 act.
Yes.
Lucidis also has a +3 act.
So coming to the next case, a 50-year-old female with 18 cut RK, and one of the flattest case that I've ever seen, around 27, 28. Now, in these cases, sir, what IOL power would you use? Now, this was the ASRS online calculator. You can see it gives you 3 readings below: the average, the minimum, and maximum. This was an 18 cut. So, what IOL power would you use in this patient? The average is 26.76.
I think I would put a 27.
Sir?
See, obviously, it's not the number of cuts that we go by,
Yeah.
but the number of flattings that have occurred, and it's quite severe. So, obviously, the principle is to go for whatever it says, go for a little higher. So, probably I would.
So the maximum is 26.8 here. Minimum is 26.76.
I would even go for 27.5, 28 also.
Okay, so here we have also put in all the Atlas ring values also. What we used was the 28. And this was the surgery. So always target myopia in post-RK patients. And I feel greater the number of cuts, probably the target myopia should be slightly higher. So I'll just stop here, sir. This was, you can see the number of cuts here. What kind of incision would you take in this patient? Even for a 2.2 millimeter incision, there's hardly any space. So ideally, probably a posterior limbal or even a scleral incision. Here, the mistake that we made was we took a limbal, but then it opened up. So if you have multiple cuts like this, probably during the surgery, look at what happens here. Even the side port, for example, because there were so many cuts that there was no other way. So one take-home message here is when you have too many cuts, it's better to take a scleral incision, there's less chance that it will open up. One controversial topic here is, would you use a toric IOL in a post-RK patient? Yes or no?
Only if there is some degree of symmetrical astigmatism.
Anybody here using toric IOLs in post-RK patients? So before we go ahead with the next case, we have used many toric IOLs in post-RK patients with very good results. But you need to do a complete workup. You need to do a topography. You need to do a holiday EKR report. See whether it's a symmetrical astigmatism under severe guarded prognosis. And we know, yes, that there could be residual refractive error. You have to explain to the patient, and then you can still go on. Now, coming to this patient, a 52-year-old, undiagnosed keratoconus. Now, let's concentrate on the right eye as of now. Look at the K1 and K2. It's 47 and 59. So it's almost a 12 diopter astigmatism. Patient has come to you for cataract. He doesn't know that he has keratoconus. The left eye is so severe that it's not even recordable. And he felt that he was amblyopic in that eye, not diagnosed as keratoconus. So if you look at the topography in the right eye, it's fairly regular but very steep case, 58 and 47. So astigmatism is almost around 11. What would you do for this patient?
Since this patient shows pretty much a symmetrical astigmatism, and however large it is, I would probably ask one of our Indian companies to customize this IOL for me. I'd probably put in a customized toric for him.
So would you use a toric IOL in a keratoconus patient?
Yeah, yes, of course, I would. This patient definitely.
So this was the pentacam, and here, as you can see, even on the pentacam, it's fairly regular astigmatism. And this was the A scan done on IOL master. You can see the astigmatism is 12.38. And we first went ahead and tried on the Barrett toric calculator, and even with a T9, the residual astigmatism is 7 diopters. So obviously we cannot use a routine toric IOL. So then we went ahead and planned for a smart toric. So a smart toric IOL, anybody who has used the Ultima smart toric?
Yeah.
Yeah, so it is something which you put in at 0-180 only, and the incision is also at 180, and here you can see anticipated residual astigmatism is 0.14. So we are targeting correction of almost a 12 diopter of astigmatism very easily with this smart toric. So it's specially customized. It probably takes a few days, but it gives excellent results. So this was the smart toric calculation, and this was the patient post-op. So from a 12 diopter, we were able to bring it down to 6.9 plano. You can see the two markings also, they are at perfectly 0-180, and the patient had a very good result. Coming to our next case, case 5, patient of childhood trauma now has come to you for cataract, and you can see how the pupil is updrawn. How will you manage this case? Haldipurkar sir?
Well, some more information would be needed. What's his the trauma has caused what, some corneal laceration?
She doesn't give any proper history. She doesn't have any old papers. All she says is she had some trauma, following which the vision in that eye has been poor. Right now, vision is finger counting. It's a very advanced cataract. So we know the cataract itself could be the cause of this blurred vision.
There
She
could
wants
be some amount of amblyopia in this eye. if
amblyopia,
it's
yeah, that she is ready to accept.
Depending on the corneal status. If the cornea is symmetrical in this, then your focus is only on cataract.
Yes,
If it's-
cornea is fine.
Cornea is fine. Then it's a state, it depends on how much the pupil dilates. If the pupil dilates well, doesn't matter. If the pupil doesn't dilate fully, then these are the cases among pupil expansion devices. It's the hooks that work best in these cases, because you need only to pull down the pupil.
So the
and to
pupil dilated well.
dilated
Now the
well.
problem is here, what I'm specifically
Peripheral anterior
alluding to
sagittal.
is
Okay.
the position of the pupil.
Okay, in that case, what you need to do is spectrotomy. Using a cutter, you can make, if at the end of the surgery, the cataract surgery is done well and the pupil comes back to this position after
Without
putting pilocar-
sphincterotomy, because we don't want to,
See, you
otherwise
can,
the pupil
you
will
can
remain dilated.
see, you can, what I would do at the end of the surgery with the forceps, with the microforceps, I would pull at 12 o'clock. And very often, even in traumatic mydriasis, if you try and pull it down, those adhesions break and the pupil does come down.
Any
So-
other input as to how you can do, what would you do for the pupil?
So one thing I think we have to do a gonioscopy before
Yes, gonioscopy.
and do a UBM. So you'll also know the status of the zonules.
All that is fine.
All that is fine.
All
So
that is fine.
then,
But you
actually
mean there are no PS?
Sorry?
There are no PAS
No.
over there?
No, there is. So actually on table, there was a tag. There was a single tag, probably because of the trauma, which was holding on to the pupil. But that was not the only problem. The problem was also the updrawn pupil. So what we did in this case was we used iris diathermy, unipolar iris diathermy on the inferior part, and we recentered the pupil and released the tag superiorly so that the pupil came to the center.
what lens did you use?
Sorry?
What lens did you use?
Lens, we used a normal monofocal laser. Yeah. So these were the various, and then a little bit about angle alpha. Since we talked so much about premium IOLs, I think this is the last 2 minutes, then the next session could be ready. Since we have talked so much about premium IOLs, what is your cutoff for angle alpha? What instrument in your clinic do you actually use? And what is your cutoff? Dr. Kumar?
I have a pentacam and I have an anterion. Unless it's hyperopic, I don't pay much attention to this.
Dr. Nagvik?
So, especially if it's a multifocal IOL, I'm
Yes.
going to look at it a little more carefully. Angle kappa is what you measure. I get my measurements from the IOL master, seeing the thing. So I get the IX and the IY, and I look at what is the. I actually do a little vector mathematics to find out what it is. So if it is more than 0.5, I've been a little skeptical. But I've been surprised sometimes that even with a 0.6, patients sometimes do very well.
This is, I think, overrated.
Overrated, yes, I
It's
agree.
overkill. Patients neuroadapt beautifully because that's how they've been seeing through that angle for so many years.
Yes. So on IOL Master 700, you get what is called a CWC, that is the Chang wearing cord. And ideally, theoretically, 0.6 is the cutoff. But even in my practice,
Multifocals,
have
huh?
you ever rejected a patient because of high alpha?
Never.
Never. Suppose it's a high hypermetrope with, say, a 32 diopter lens. Then would you reject?
No,
No?
no.
So you'll be surprised. Technically, hyperopic LASIK is a contraindication for a multifocal, right? Because you're creating the same bad things for both the cornea is bad and the lens is bad. But I have done at least 6 patients, so 12 eyes, with hyperopic LASIK and a multifocal, trifocal IOL, and patients are extremely happy.
No, why I wanted
So-
to ask is this
No, what I
angle
meant
alpha
was-
is specifically for high hypermetropia.
Yeah, but they adapt very well, according to me. I have never rejected a patient.
Aldipurkar sir, your inputs.
Well, I mean, 0.5 is a cutoff for me for both. But then I have no experience with doing it for high hyperopes because I wouldn't be very keen to do it for more than 30.
My first encouragement came from a patient himself. He said, I never saw well for distance nor for near all my life. So, doc, do something for me. I explained that this is likely to happen. He said, do it. And I did it. And he was like 6, and 5 the next day. So, the next day, there was no question of adaptation. So, I think, we have to also always look at what the mindset of the patient is and what the patient wants to do from these
Right.
cases. So maybe it's not a bad option to do. Yeah.